Floor is yours. We'll talk about ERCP, difficult cannulation.
Thank you for having me. It's really an honor to come back to Riyadh. I want to thank Rashid and Abed for inviting me again. It's really a pleasure to be here with so many friends and esteemed colleagues. So I'm going to be talking about biliary cannulation, go over some tools and tricks. We're going to really try to understand what are the position, what are the instruments needed to do this, what are the typical technique, what do we do when those doesn't work, discuss a little bit about pre-cut, and I'm going to very quickly brush on EOS guided as an alternative. Tomorrow there is a talk on this. Why is it important? It's important because we need to be able to increase our success of biliary decompression, and we need to make sure that we have less complication. This is why this talk is very important. The very important thing about cannulation is the prerequisite for any biliary intervention. If you can't get into the bile duct, really there's nothing you can do anymore. So the very first step to do when you're doing an ERCP is really taking your time and try to assess the ampulla. You have to see where is it? Do we have bile flowing? Is there any manipulation, any scarring? Is it a floppy papilla? Is there's a diverticulum? So you have to spend some time exploring this anatomy. There is three types of channel: a short common channel, a no channel at all, and a long common channel. Most people have some kind of a channel, and then it's very important to understand that so that you can prevent unnecessary cannulation into the pancreatic duct. Two types of position is used: short position, long position. Long position is when you have a very difficult anatomy or redundant small bowel. In most cases, we recommend trying to do a short position by emptying as much as you can the air from the stomach so you can get that position. So the idea is really to put yourself, when you want to get biliary cannulation, below the ampulla, a little bit on the right side. So you're really coming from below to the left. And that's a very important concept, is really take your time in getting this position. Two types of device has been used historically for cannulation. The cannula, and most of the previous generation used to use cannula for cannulation, and everybody has now shifted to a sphincterotome. The reason why people used to use cannula is because at that time it was felt that to be able to appropriately cannulate, you needed to inject. The problem of cannula, it can be extremely traumatic. They're very stiff. You cannot bend them, and it's very difficult to adjust the anatomy to the cannula. The beauty about the sphincterotome is like you can bow it whenever you need it, so you can really get into that angle coming from below up, coming from the right to the left. And I think that's what's happening now. I think universally most people has now shifted to a sphincterotome, what we call the double or triple lumen sphincterotome. Why? Because they're going to be now a guide wire. So here we are putting together all the pieces of the puzzle to obtain a good cannulation. It's a sphincterotome preloaded with a wire, so you can inject, you can bow, and you can advance the wire. So you can see here the typical classical position when you're trying to cannulate with something that is stiff. It's cramming skirts. You're basically jamming it in, while when you hook and pull, you basically can do that with a sphincterotome. By hooking and pulling, you're lining up into the angle of the ampulla, and I think that's one of the advantage why most people have now shifted to the sphincterotome for cannulation, because it's going to allow you to do that phenomenal bow. Now, there is really two ways to cannulate with a sphincterotome. There, from a distance technique where you put yourself very close to the ampulla. Some people might touch it just a little bit, and then very gently you advance the wire. And there's people that like to cannulate directly and then advance the wire. There's no data that's showing either of those techniques is better of them, because most of the people now are not injecting and trying to systematically use guide wire. So the beauty about guide wire cannulation is, one, it prevents injection of contrast. Number two, in most cases, if you're on the right angle, the wire will go into the right direction. However, be aware that if you push the wire too aggressively, you can create dissection of the papilla, false track, and the feared complication of perforating the pancreatic duct side branches. So you have to be very careful, especially when you have a redundant or floppy papilla, or when you have a stenotic papilla. In this case, you actually are obligated to do full cannulation with the sphincterotome before advancing the guide wire. But you can see here that the data about using guide wire is very interesting, because it seems to favor it as long as it's done in expert hands. Same thing when it concerns post-ERCP pancreatitis. You seem to have less post-ERCP pancreatitis because you're injecting less. So it's very important to look at those kind of studies, because those studies are the ones that we're using to change our standard. This is why we shifted slowly but surely to using guide wire and a sphincterotome as a technique. So there's different way to succeed when you have issue, when you have a difficult cannulation. You can change the patient position. Sometimes just by doing this, it helps. You can do a precut. You can do a pancreatic precut sphincterotomy, which is through the sphincter, or called the Goff procedures. You can try to deal with the diverticulum, and of course you can remove the ampulla. That's done very rarely, but that's an option. And you have EOS guidance as an option. So let's talk about the double wire technique. Let's say you keep on getting into the pancreatic ducts. At one moment, the idea that you want to do is actually you occlude access to the pancreatic duct by placing a guide wire, and then by advancing a second guide wire, it's going to bounce against the first guide wire and get into the bile duct. So I'm going to try to show you this video here quickly. Here it is. So you see here we cannulating the ampulla very nicely, and we're trying to get into the bile duct. We're trying to bow, and you see we're trying to get the position, as I said, coming from the right side to the left, coming down to up. We're bowing, we adjust in the position. Notice the ampullary diverticulum here, and you see we're injecting contrast, and the only thing we can get is the pancreatic duct. We try with the wire to get access into the bile duct, and then finally here we were able to do this. And I think that's what's important, is once we have the wire into the pancreatic duct, it's going to be much easier to get to the bile duct. Why? Because the first wire is occluding access to the pancreatic duct at this stage. And if you adjust and adopt a biliary position, remember down, up, right, left, you can see that in this case, the wire is going to hit and it's going to go into the bile duct. And here we have access into the bile duct. And I think that's the beauty of the double wire technique. Now, if everything fails, and usually what I recommend to my junior faculty or my advanced instructor when they're training, start with the double wire technique and then move on to the pre-cut technique. And data seem to suggest that instead of spending hours and hours struggling, sometimes moving faster to a pre-cut technique might be safer. So there's different pre-cut technique. There's the papillotomy, where you basically, with a needle knife, you open the papilla. There's a fistulotomy, and there's the famous Goff technique with the transpancreatic sphincterotomy. So the pre-cut papillotomy really is, with a needle knife, you're going to expose layer by layer the papilla, and the idea is finally exposing the bile duct. So you have to be very careful, because if you do it not layer by layer or too deep, you can actually go through and through and create more complication. So the idea here, as you can see, is very gently accessing layer by layer until you see something that looks like the bile duct in terms of appearance of the epithelium, or you see bile coming out. And then as soon as you have that, you can then place the wire into the biliary tree and then finish the sphincterotomy. Now, the biggest problem of this is complication, and very fast they started advocating, especially the Indiana group in 1995, placement of the pancreatic duct to protect the pancreas, and then finish the needle knife sphincterotomy over the pancreatic stent. And that is a very elegant technique, especially if the only access you have is the pancreatic duct. And for interest of time, I'm gonna keep on going and talk about fistulotomy. Fistulotomy is something that you want to do when you have a bulgy ampulla, a very, very generous big ampulla Those are the ones when you have an impacted stone that prevent you to get into the bile duct, an ampullary cancer, ampullary adenoma occluding the bile duct that is very bulgy. It's pretty safe because you are away from the orifice of the pancreatic duct by just basically perforating and creating a fistula that will get you access into the bile duct. The transpancreatic sphincterotomy basically consists on cutting the septum between the pancreatic duct and the bile duct. That's going to allow you to have easy access. The beauty about this technique is if you keep on getting into the pancreatic duct, you already have access into one of the ducts, so it's very easy to find the bile duct access once you have cut the septum. You can see that when you compare the data of a biliary sphincterotomy conventional pre-cut, there is definitely more complication, and this is why most people try to avoid as much as you can those techniques and resort to other techniques that are less invasive. For instance, fistulotomy seems to be safer because simply there you just go in for the bulgy ampulla above the orifice of the pancreatic duct, preventing hence the risk of post-ERCP pancreatitis. Diverticulum is something that's, you have to deal with. You can use a clip. You can create a submucosal injection to basically divert the ampulla away from the diverticulum. And then some people haven't even described doing an ampulectomy to expose the bile duct and the pancreatic orifice. This has been done. Michel Kremer did one of those in front of me when I was still in training, and I think this is why I fell in love with endoscopy. Now, when everything fails, nowadays we resort more and more to EOS-guided biliary drainage. I'm not going to spend much time on it. Tomorrow there's a dedicated talk about it. But the idea really is to use access either through the liver, which is basically transhepatic, intrahepatic access, or outside the liver, which is extrahepatic or choledochal access. And then once you have a wire advance through the ampullary orifice, you can do a EOS-guided rendezvous. I'm not going to spend time on this, but basically this is a nice last resort, and this is how you can salvage your biliary access. So basically the take-home message is very important to understand the anatomy. Mastering cannulation technique is crucial for any advanced endoscopist because this is the start of any biliary intervention. Wire-guided cannulation is now, with the sphincterotome, is really the gold standard. You have to know all the technique that you can use. Pre-cut should be attempted if you've tried a double wire technique. Very important not to wait too long and deal with a traumatized ampulla before doing the pre-cut. You may as well resort pretty fast if you tried all the other technique. And then finally, if you fail, you have to start considering other access, such as EOS-guided biliary access. And never, never forget to stent to prevent infection or cholangitis at the end of this. I want to thank you for your attention. If you have any more questions, you can scan the logo there and you'll be able to access my email and contact me. Thank you so much.
Thank you, Dr. Kahaleh, for this outstanding